Today we're going to talk about raising awareness of the options that's available for antenatal care or pregnancy care as we call it in Perth, Western Australia. Every area has its own models of care. I'm just going to share my experience of what has been happening in terms of antenatal care in the last 15 years that I've been working here. Hi, I'm Dr. KaviPriya Soma, a GP with special interest in women's health, and I'll be talking about antenatal care with our lovely midwife, Beau Wilson, who is an endorsed midwife, and we both have been providing antenatal shared care in our clinic called Athena Women's Clinic. Please talk to your own healthcare professional, but remember, we are also available for your care. Today, I'd like to explore the topic of antenatal care or pregnancy care with our lovely midwife, Beau Wilson here.
Hello, and thank you so much, Dr. Soma, for having me with you today.
So, Beau, tell us, when do you actually think the antenatal care should start?
Well, ideally, we would like to see women preconception, so in the months where they're planning to have a baby, and so that we can use that key time to talk about some really important concepts of preconception care.
I think it's really important that they see both the GP or their own healthcare professional and the midwife to start planning their pregnancy. Like Paul mentioned, it starts with the basics, and I don't think we can go wrong if we stick to the basics. The advantage of having the endorsed midwife looking after your care would be the continuity of care which starts pre-pregnancy, antenatal. Tell us, Beau, when do you think that the antenatal care should start?
Well, from my perspective, ideally it would be really nice to see women and their partner preconception, so in the months in that they're planning to have a baby, so that we can use that opportunity to really discuss, the really key elements of planning a healthy pregnancy in terms of nutrition and lifestyle and things like that.
Okay, that's really good. So if the woman has their own healthcare provider, so they have their own GP, then what is it that you can do different in terms of counselling or care that you think you can provide differently?
Yeah, as an endorsed midwife, we have a really important role, and we are able to really get to know the woman. So we have a lot more time with the woman and her partner or family to really go through those key points of interest and education. So we can talk about the woman's lifestyle, any workplace factors that may need adjusting in terms of having a healthy pregnancy, and we get to talk about education. We also just get to talk on a human level about how she will prepare in becoming a mother as well.
That's great. Like you say, I guess the GP's role is to look. It does become a little bit medicalized, although there's the psychosocial factors involved. But I think there's a lot of medical factors that do come into play. And with the time constraints, it would be wonderful that you can complement that process and enhance the outcomes of the couple or the pregnancy itself, isn't it? So in the preconception care, I know you mentioned you touched upon a little bit about their workplace and what they do, but do you also go in depth into their nutrition, psychology, and things like that?
Yeah, absolutely. So we like to really talk about, the choices that women are making in terms of what they're eating. There is a lot of gestational diabetes, of course, and other lifestyle factors that can increase risk factors in pregnancy. Mm-hmm. So there's lots that can be done in terms of exercise and nutrition before you become pregnant. And of course, I'm guessing your role too is to also advise about women's blood tests and things like that, and how they can optimise their health in terms of doing taking pathology and things to advise on that.
Yeah, that's a good point, because as GPs we are trained to do those things. We go through their previous medical history, previous obstetric history. We may delve a little bit into their nutrition, but probably not as much as every GP should. I get it because of the time constraints. And there is quite a misconception about exercise in pregnancy as well. So there's lots of things that we can explore, but hopefully Medicare will wake up soon and we'll have more, item numbers that we can help with the women as well. But like you said, we can organize the preconception testing for the general aspect of like checking their iron levels, their vitamin levels, their sugar levels to make sure that they're not diabetic or pre-diabetic in their state. And also getting to know them, because we have a lot of culturally and linguistically diverse population, and what may seem normal in one culture could be totally abnormal to another person. And I think that's where the collaboration helps, because each of us bring our own perspectives and breaking it down into simplified terms for the woman would make it easier. And having that relationship and that support system is really important. Unfortunately, in the past, we all had big families which worked as great support systems. We don't have that anymore. We are reliant on professionals like you and me and their own healthcare providers and GPs who can provide those opportunities. So if we were to give them the advice about, let's just say, simple stuff like nutrition, where would you start?
Basically, just really tuning into what's good for the individual, because I think there's lots of standard guidelines out there, and we need to listen to the woman and what her wishes. Their cultural aspects we take into consideration, and mostly one very big important thing, of course, with gestational diabetes is just stabilizing blood sugars, and this is also comes into play with women with hyperemesis and nausea. I find a lot of women skip meals for lots of reasons. So look at eating regularly, just the basics of eating regular meals with some protein, lots of green leafy vegetables for iron intake. Adequate hydration is really important as well. And I know you see in clinic every day so many women in pregnancy with iron deficiency, and ideally we would like to address this before pregnancy, because obviously when an iron infusion is necessary, sometimes it is, but it would be ideal if we could address that beforehand with diet changes and things like that, because once you're pregnant, your baby is needing lots of nutrients and things, and we're working sort of steeper hill, so to speak, in terms of
so I think it's like preparing the soil before you sow a seed, and many people miss it. So here we have this opportunity to educate. So that's really good that we can do that for the women. Secondly, what would we say in terms of exercise? Controversial topic.
Look, I support women with whatever exercise they're doing currently. I think they should continue it as long as it feels good for them. I always tell women, if you're feeling pain when you're exercising, if you have any vaginal bleeding, you need to see your care provider and maybe make adjustments to your exercise regime. It's not the best time during pregnancy to take on new sports and exercise, but definitely like pregnancy yoga and walking are always good for most people. So
I think I concur with what you have just said, and I pretty much give similar sort of advice to say, please don't, there is no necessity to stop exercising just because you're not pregnant. Although, unfortunately, culturally, most women get told that you should stop exercising as soon as you figure out that you're pregnant. But like exactly what you said, tone down the intensity of the exercise, but keep continuing. And second point, don't start anything new. And I think we both concur on those facts. That's really, really good and reassuring for many women, I think, to know that continuing to exercise, the pregnancy outcomes are so much better. And I think that's an important thing to emphasize as well. What would be the next lifestyle advice that you would give the woman?
Well, I think it's important to look at any chemical exposure or even workplace or home hazards as well. So we are exposed to so many chemicals and toxins in our environment day to day. And I think it's for a lot of women, once they become mums, they really start to question their lifestyle choices and what's best for their children. But in pregnancy, absolutely, we can make changes in terms of even just the chemicals in our home, cleaning products and things. If you are doing renovations, it's a common one we see in pregnancy, and you're painting, you definitely need to reconsider that, potentially having someone else do it, or at least, looking at certain safety wear and things like that to decrease the toxin exposure in pregnancy. And as I said, healthy eating and good healthy food that doesn't include lots of chemicals and toxins and things like that is really important. So
I wish we can find something like that has got less, toxic exposure. Unfortunately, even the organic ones that say they're organic are probably that. So in concurring with what you have said, I think one of the other important things is also infections that you can contract through workplace. So if it is important for the woman to remain where they're working, so we both can actually plan what sort of preconception testing that is needed. And I'm sure you're aware of the genetic carrier screening testing that is available through Medicare now, which I think we also discussed during this preconception visit. Right, and where do we go next in terms of supplements?
Yes. Well, that's also a great time to see a GP to talk through those things. I actually also do suggest for some women to consider seeing a naturopath, especially in the preconception stage, because naturopaths just have that time to go through really on an individual level where deficiencies lie and how to choose supplements that our body responds to the best and helps to increase any deficiencies or effectively increase different vitamins and things like that are required. Definitely, as we've talked about, iron is such a big one that really does need to be addressed, ideally before pregnancy or earlier on. Vitamin D deficiency is another one that's very, very common, especially in our clinic and demographic of women. And what do you think?
Oh, look, coming from where I come from, as you know, I come from India, the iron deficiency was so common. So when I moved to Australia, I thought, Australia is a developed country, I would actually not see any deficiency. But this is going back 15 years ago. It was a total eye-opener to realize that iron deficiency exists even in a developed country, and we still have to follow the same sort of advice that we give women. So it was a total eye-opener. So like you say, I do emphasize on healthy eating. I think, like you say, seeing a naturopath, perfect. But the general principles will be based on their culture and sticking to whole meal foods, fruits, vegetables, basics. I think it's easier and then they can prepare and choose how they want to have that. And in the process, not losing the nutrition as well. But other things that I do come across is also sometimes drug and alcohol use as well. So not many women actually reveal that to me as a GP, but I find that they reveal these things either to the midwife or the nurse even. It's very, very strange because we ask the questions. Maybe I don't know if I'm a bit blunt with them, but then I find that once they've seen this, oh no, it's occasional, it's something like that. And then the next visit they see you, and when I read the notes, I think that was not even half of what they're they're actually doing. So it's great that sort of relationship that they develop with you guys. So how would you approach that? It'll be nicer for us to know how you approach differently from how I approach that same question.
Yeah, I think having longer appointments is definitely to our benefit. We just have that little bit more time to establish rapport and help the woman to feel comfortable and trust in the partnership that we create. And that's why the continuity of care, having a familiar face, is really beneficial. But definitely we'll want to ask these questions early on, but potentially not at the very beginning, at the very first appointment. And also just wording questions in a certain way. Actually, an alternative is actually to give them a written piece of information that asks about this. Some women tend to be a little more comfortable telling the truth on paper rather than face to face, which is understandable. But always the aim there is to give them early advice and intervention if they're willing. And with smoking, it is more common than one might think, smoking in pregnancy. And it's obviously a very difficult addiction to combat, but obviously the aim would be to reduce, and a lot of women are able to with the right support. Yeah.
And many women have asked me the question if they can actually use the patches to quit smoking. Although it's not the best option, but I think it's better than smoking.
Yes.
So I think that sort of information and counselling is important. And it's also important that 2 or 3 health professionals concur in the advice to increase the confidence in the care that's being provided to the woman.
Yes.
Because if you and I say different things, then they're going to be left with more confusion rather than actually implementing what you're trying to tell them, isn't it?
Yes.
But
another important part, I think, if women are smoking or using drugs, there is often some other psychosocial factors that interplay with all of that, and it's a really good opportunity to start to talk about them and become aware, and where we can actually offer more emotional and mental health support that can then alleviate those stresses and help those women to reduce smoking or drug use as well. So
that brings me to this important thought. You know what? Most women, when they're in the pre-pregnancy planning, they come to see a GP by themselves. But I think when they have the opportunity to see you guys, they come as partners. And that's actually a privilege that you guys have, that you get to see that interaction between the couple per se. And I think you have the opportunity to emphasize the support of the partner in their ongoing planning and care, isn't it? So, like you say, the psychosocial factors would, and if you're seeing it in the context of the family, I think it makes a little bit more emphasis for them to follow through with the care rather than just come as an individual, take, oh yeah, she said this, and walk away from it.
Absolutely, yeah. And partners play a huge role in the whole experience, and even often sometimes the woman does not smoke, but the partner does, or someone in the home. And that's also an important topic to chat about and educate women that, there can be things that can be adjusted once baby's born, especially if a partner or close family member is handling baby, to wash hands before holding baby. Smokers can wear like a smoking jacket outside when they smoke and remove it when they come in to see baby. So, all of those things really do matter, and that's why midwives do see the woman not just as an individual, but as a part of her family as a whole as well.
Perfect. So now we've come to the part where she does fall pregnant. Where do we go from here? So I think usually they see their own GPs or healthcare professionals, and once they've got a confirmed pregnancy test. But I think there's lots of early pregnancy issues that the woman can face, and sometimes it's very difficult because the GP who is looking after may not be well versed in the early pregnancy care, or they have limited access. They don't know where to access services. EDs are overwhelmed with a lot of acute emergencies. So if we don't support these women, then they end up in the ED waiting for 4 to 6 hours, and sometimes they walk out there without much help or with very limited options. You and I have both discussed about early pregnancy, but let's just, I think we need to really talk about this to raise awareness that what can be normal in early pregnancy. Some women have vomiting, some don't have vomiting. Both are problems.
Yes.
So somebody says, I actually don't have vomiting. So is that normal? And then someone's like, oh my God, I've got so much. How do I manage? So I guess I provide the medical aspect of, what is needed as in hydration, medication. But I guess you can take over the psychological support of if it is normal or not.
Yes.
Unfortunately, because we don't have the social support in terms of bigger families, you and I play a very important role in this. So how would you talk to the woman in such a situation differently from what I say to her?
Yeah, so I do look at all of those psychosocial inputs as well. And actually there's some great groups, like peer groups for women with hyperemesis in pregnancy. So something like that can be a very good sort of emotional support for a woman experiencing that, because it can be very, very, very challenging and debilitating. But other than that, looking at all the supports available to her, she might need to make adjustments to her work in those early weeks. And that is the best thing about seeing a woman early on, so we can talk about what, aches and pains might be common or expected, what is normal, what might need some more input from your healthcare provider, and having regular appointments with your GP or midwife early on so that we can offer you that reassurance and things like that. It's very important.
And I think it's really important for us as GPs to understand that you as a midwife can start providing care from early on, because traditionally women were referred to you for more than like 13, 14 weeks, isn't it?
Yes.
And then in the hospitals, it's still a bit later. So it's good to know that, how the healthcare professionals can understand that you actually play an important role right from the beginning, like preconception through to early pregnancy, and then, the actual pregnancy itself. So that's really supportive as well. So where we can't afford to give the time, where you can, that would really help us. So that's So when the woman comes to see me in early pregnancy, I guess I do their investigations for their routine antenatal care, as in the infection screen, blood group, their iron levels and their vitamin levels. And of course, we organize a dating scan if the woman is unsure of the dates. And it also gives us information on how to plan for the course of pregnancy, making sure that we get the due date correct. But most doctors or GPs, because they are new to the country or they haven't worked in the system for long, or they have not had exposure to the hospital network, I think it's difficult for us to understand what are the models of care that's available. I'm a GP also, I do know that that model exists, but what are the other models of care that the woman can choose? And I presume that it's at best the woman's choice, of course, within the limitations of the medical and obstetric limitations, isn't it?
Yes, I agree with you, yeah. But it is a very individual choice. So what we see and what we hear from women is often they will see their GP and the GP asks them, do they have private health insurance or not? And if the woman has private health insurance, they will choose their chosen obstetrician to look after them. Or if they don't, they will be often referred to their local catchment or local hospital for care. But actually there's lots of other models of care available to women. And that's where midwives are really well placed to have the time and the knowledge to discuss all those models of care chosen. And because it really will impact the woman's pregnancy care experience, the type of model of care they choose. So for some women, having an obstetrician look after them through the pregnancy will be the best choice for them. They feel safer in that type of environment with really close care and surveillance of the pregnancy. But for some other women, they really do value the continuity of care with a known midwife. So a few models of care that are available really depends on the state the woman lives in and even just the town and the facilities. So it really does differ. What we provide is, GP shared care with Endorsed Midwife, and we share the care with the hospital mostly. But for some women who have a pregnancy, especially with no pregnancy risk factors, they might want to choose to employ a private midwife for home birth. And there are also other models of care either based in a hospital or attached to a hospital, like the Family Birth Centre. So the Family Birth Centre is more for women with low risk pregnancies. It tends to be quite a comfortable home-like environment, and they will often have one or a few named midwives looking after them throughout the pregnancy. So they do still enjoy the benefits of continuity of care through the pregnancy. There are midwifery group practices available in some of the hospitals. Again, the woman will be assigned a small group of midwives who will be responsible for looking after her through pregnancy, birth and beyond, and also birthing in a public hospital or private hospital under the care of an obstetrician. So there's lots of models of care, and as you say, it depends on the individual and her wishes, but it also needs to suit physical and emotional health as well throughout the pregnancy.
Adding to that, of course, the previous medical history, the obstetric history also would determine her model of care. And I know you mentioned the private health cover, but people forget that on the private health cover, they are supposed to have private obstetrics cover. So just having private health cover doesn't entitle them to automatically get private obstetric cover. So that's where I think people go around thinking, yes, I have private health cover, so it'll automatically take me to the private obstetric cover. That's good to know for the women, so they can choose, like you say. Similarly, the home birthing program, I believe that they also need to have a hospital attachment. Even though they may birth at home, the local hospital needs to know that if there is an emergency, then they can support them.
Yes.
So they need technically an approval from the local hospital obstetric team to say they are okay to birth at home.
Yes.
I think those two things, and it's at the end of the day, it's safety for everybody and better outcomes for both mother and child, isn't it? So now that we have done the bloods and the scans, and they're here for their next part of pregnancy care. So that was a brief discussion of early pregnancy care with myself, Dr. KaviPriya Soma, and Beau Wilson, our lovely midwife. So if you would like to continue to listen to the next part of antenatal care that you were going to talk about, please stay tuned. Or in the meantime, if you'd like a bit more information, you can go and visit athenawomensclinic.com.au. But please also inquire with your own healthcare provider. Thank you.